Welcome to today's MESUD Learning Community webinar. Today we'll be hearing from Dr. Jonathan Fellers on ketamine therapy for substance use disorders, theory, evidence, and limitations. My name is Bethany with CCSME and I'll be supporting today's webinar. Just a few quick notes before we begin. First, neither the presenters nor the planners have any relevant financial relationships to disclose. This activity has been planned and implemented in accordance with accreditation requirements and policies of the ACCME through a joint providership of the Hanley Center for Health Leadership and Education and CCSME. The Hanley Center is accredited by the MMA Committee on Continuing Medical Education and Accreditation to provide CME for physicians. The Hanley Center has designated this activity for one AMA PRA Category 1 credit. The opinions expressed by the speaker in this webinar are their own and do not represent the position of the state of Maine or CCSME. Recording and live stream transmission of this webinar without consent is not permitted. We'll have a few minutes at the end of the presentation for questions and answers, so please hold all the questions until that time, and you can place them in the chat feature in Zoom. Slides from today's webinar will be sent out in the follow-up email. And now I'd like to give a quick introduction to our speaker today. Dr. Fellers is an addiction psychiatrist who works with patients, families, and our healthcare system to promote high-quality evidence-based screening, assessment, and treatment for substance use disorders and co-occurring mental disorders. Currently, Dr. Fellers serves as medical director for 2 treatment programs. At Crossroads, he oversees and delivers a gender-responsive addiction, eating disorder, and behavioral health treatment for women who in 2 residential programs and 2 IOPs. Through Foundation House, he supervises an extended care residential program that combines transitional sober living with clinical services for men aged 17 to 35. He also operates a small private practice and serves on the board of Portland Community Recovery Center and the Law and Addiction Committee for the American Academy of Addiction and Psychiatry. And with that, I will hand it off to Dr. Fellers for our presentation. Thank you all for being here today.
Great. Can everybody hear me okay? Thank you for inviting me to speak. This is a really interesting topic, and so I do have quite a few slides. Hopefully I can get through everything in pretty good order. But what I'm going to talk about today is ketamine therapy for substance use disorders. This is a very popular and hot topic right now. It seems like everybody is talking about ketamine and psychedelics and this new wave of treatments that may be kind of on the horizon. And so it's an exciting time to be in the mental health field. Let's see. There we go. I do plan to discuss unapproved or off-label uses of approved pharmaceuticals, so ketamine and Spravato. They are not approved for the use in substance use disorders, so that would be considered off-label. And I do have to disclose that Janssen Pharmaceuticals, which manufactures Spravato, I have received lunch from them. I don't think it's going to really impact this much, but it's somewhat related because Spravato is esketamine and somewhat relevant to the topic. Oh, doesn't like that. So our 3 objectives, which I hope to get done today, will be understanding kind of why ketamine might be helpful in addiction. And then what we'll do is we'll take a look at a lot of the research that has come out about ketamine and its use in addictive disorders, and then kind of in the whole process try to identify the limitations as the current evidence is. Obviously, it is not FDA approved, so that is a significant limitation at this point, but it may be something on the horizon. Oh, I keep on going there. All right, so I think a first place to start is kind of understanding the pharmacology or what ketamine is. And I think an important place to start is with PCP or phencyclidine. PCP first was kind of synthesized in 1926, but it really wasn't until the 50s that it was really explored. It's kind of the progenitor of a new kind of class of medications called the dissociative anesthetics. This was kind of termed because there was an observation of people under its influence. They seemed to be dissociated. They weren't like within themselves. And it was developed as an intravenous anesthetic. And unlike other anesthetics, like inhalation anesthetics, other things, it is a distinct mechanism. It induces a trance-like state, almost catalepsy. That's how it's described. So a catatonic, almost like state. And there's preserved respiratory drive and airway reflexes, which is really important because most anesthetic medications kind of suppress respiration and often require, respiratory support during procedures. And because of that, it can be used without cardiopulmonary support. It also stimulates heart function and blood pressure, and therefore, it doesn't always need the anesthesiologist as much there supporting respiratory and cardiopulmonary function and to the same extent. There is a risk of emergence reactions, which is the reason that PCP was actually discontinued in 1965 because it had an unacceptably high rate of patients becoming very agitated, delusional, and irrational. And so there was an interest in searching for safer analogs of PCP that may also have some of the good benefits of dissociative anesthesia, but with less of the hallucinogenic effects. And so ketamine first was synthesized in 1962, and you can kind of see that it looks pretty similar to PCP, kind of that same aryl cyclohexane backbone. And it was FDA approved in 1970 as an anesthetic medication. It is somewhat limited in its use because of emergence reactions. It's a lot lower risk of it. About 10 to 20% of adults will experience an emergence reaction. But where it really found a lot of use and utility was during the Vietnam War, because as a dissociative anesthetic, not suppressing respiratory drive or cardiopulmonary function, if there was a wounded or a trauma in the field, they could be sedated and brought back without needing an ambu bag or other things to kind of support it. And so it had a really good utility in responding to traumas when supporting respiratory or cardiopulmonary function would be otherwise impractical. It also kind of found more niche uses um, in surgical care, kind of like burn dressing changes, which are notoriously very painful, but do require awareness and to be able to move. And so it can be very effective there. And in children, they really have only a tenth of the risk of an emergence reaction, so like 1 to 2%. And so for pediatric procedures, ketamine had more use. And then veterinary, where it's not as much of a concern. In the 80s, like most medicines in psychiatry, we like find out that the medicine works, but we don't know how it works until after we've been prescribing it for a while, and then we find a mechanism. Same is true for ketamine and PCP, discovered in the 80s, and it's thought to be primarily non-competitive antagonism at NMDA receptors, which NMDA is a subtype of receptors that glutamate or excitatory neurotransmitters bind to. And there's a specific PCP binding site that's you can kind of see in this diagram that ketamine also binds as well. And so the action of anesthesia is basically by blocking these excitatory neurotransmitters, you're overall suppressing neural activity and inducing anesthesia. There can be profound analgesia as well. And what happens is, as a dissociative, the pain or afferent fibers don't actually make it into the cortex. So like there's like a prevention of spinal cord transmission of pain. And so people are literally dissociated, not feeling what's coming in. And then it also has psychotometric effects, and it has been maybe perhaps an even better model for schizophrenia compared to like an amphetamine-induced psychosis. The NMDA antagonist model of schizophrenia is one that we still use. It's not perfect, but in addition to like the previous model of the dopamine, of too much dopamine, um, there were some failures of it. That model did have delusions, hallucinations, but it lacked the negative symptoms characteristic of schizophrenia, such as autistic withdrawal, anhedonia, cognitive defects. And the NMDA receptor antagonist model includes those models, includes those features as well. And so is maybe a more appropriate model to be using. And those are the effects that people, that you want to avoid in anesthesia, but in some ways we are seeking in for other reasons. It also activates a variety of opioid receptors. And so it's not just working on NMDA receptors. There's mu receptors, kappa receptors, and an interesting phenomenon is if you use an opioid blocker like naltrexone or naloxone, it does not alter the analgesia that can come with ketamine. And so the analgesia is not dependent on the opioid pathway. However, the antidepressant actions that we'll talk about later is attenuated through the opioid blockade. That does not necessarily mean that the way ketamine works for depression is through opioids, but opioids may be a critical part of the pathway. It may not just be opioid agonism, but that signaling is important in its mechanism. So you can block actually the antidepressant effects of ketamine if someone is on an opiate blocker. It also induces a cascade of glutamate and GABA signaling. So there's can be this post-glutamate surge afterwards, after the antagonism stops, as well as transcriptional regulators and neurotrophic factors. And this whole cascade of actions is really thought to be, at least currently, how ketamine works for some of these other indications. Meaning, in animal models, it's been demonstrated that ketamine's able to reset networks that have become unbalanced, so reestablishing a normal homeostasis. So an unbalanced system may have been unbalanced. And that has been kind of also demonstrated in humans where kind of these states of maladaptation can be reset and return to a normal homeostasis, such as opioid-induced hyperalgesia. So this is a phenomenon where opioids actually precipitate worsening and hyperalgesia rather than treating the pain, which is kind of a phenomenon of central sensitization as well as pain windup, kind of like with complex regional pain syndrome, where there can be a cycle that it winds up the whole process and upregulates and has a new an abnormal homeostasis, and you can reset it. And it's also thought that's probably how it is working in depression, that as a result of the depression, people are kind of stuck in this maladaptive spot, and the ketamine enables people to kind of reestablish a new norm from that point. I'm going to keep on doing that, I think. So let's talk about this, like knowing what I just said about the pharmacology, and let's talk a little bit about how it could impact addiction. So this is one of the bigger models of describing addiction neurobiology, where there's three characteristic phases. There's the binge intoxication, where substances cause increased dopamine tone in the reward center, and that leads to binge intoxication, reward, increased incentive salience, development of craving, and people cannot stop that continuous cycle of use. And then when when use is stopped, there's a characteristic withdrawal or negative affect stage, both acute withdrawal as well as kind of a post-acute withdrawal. So because of the constant presence of dopamine, there's a relative hypo dopamine function, kind of like anhedonia, decreased pleasure and enjoyment in activities, as well as upregulated stress and poor mood. And then people go back into a preoccupation and anticipation where cues can trigger the redevelopment and reactivation of that reward center, leading to more drug-seeking behavior and return to use. And that's basically how addiction develops in one slide. So like it's actually establishing a new homeostasis, an altered or abnormal homeostasis as a result of the continued use of a substance. So let's talk in a little more detail about the withdrawal negative affect stage. So part of that stage is, since there has been a lot of dopamine functioning in the nucleus accumbens, as a result of that, there's an overall downregulation of the density of dopamine receptors there. And there's also a relative upregulation of activity in the amygdala. So a consequence of that is that you have the anhedonia, no motivation, and kind of what I would describe as how 12-step program Alcoholics Anonymous would say they are restless, irritable, and discontent. That's kind of exactly what the withdrawal or negative affect stage is. Restless, anxious, irritable, and discontent. Nothing seems to be satisfied. In addition to those dopamine changes and the upregulation in the amygdala, there's also activation of hypothalamus, pituitary, like that whole axis. So you have increased cortisol, stress responses, and norepinephrine as well. So stressed as well. That mechanism of kind of that discomfort of use, one way of looking at that is a reason people keep on using, because going through that characteristic withdrawal stage, it can lead to negative reinforcement. The hair of the dog, taking the substance to take away the punishment of a withdrawal syndrome. Um, and so one example in which ketamine may be helpful as far as addiction is looking at precipitated opioid withdrawal. So people with addiction who chronically use an opioid will develop a new set point, a tolerance to the presence of opioids. And one of the interesting things about ketamine is, since it can facilitate through neuroplasticity resetting those new homeostases, animal data also demonstrates that it can mitigate precipitated opioid withdrawal. So when given naloxone, ketamine lessens the degree of opioid withdrawal someone would experience. And they've extended this into human trials. So one trial taking a look at 31 people, long history of opioid use. So these are actually people with chronic pain on high dose opioids, and they're on such high doses that what they wanted to do was get them on lower doses, more practical doses, and it was very difficult to do that. And so what this study did is it looked at rapidly precipitating it and then using ketamine at the same time to help facilitate that rapid loss. And what they found is ketamine does this. It allows people to more rapidly detoxify from opioids with significant opioid tolerance. And they saw a normalization of physiologic markers of it, such as EEG and evoked potential. So it's actually altering what would normally be a very uncomfortable withdrawal and making it less, allowing plasticity, allowing new homeostasis more rapidly. Another study took a randomized placebo control, took a look at 58 people, and this time with opioid use disorder. And they were undergoing acute withdrawal with the goal of getting them kind of on naltrexone, an opiate blocker, which is one of the biggest challenges with treating people with opioid use disorder with naltrexone or depot naltrexone, because typically you have to detoxify them and then you have to wait long enough so you don't make them more miserable by giving them the antagonist. And in this study, they found that the ketamine helped normalize the autonomic symptoms and cortisol concentrations that are characteristic of withdrawal. So allowed a faster and more rapid withdrawal process. Pretty interesting. Um, um, to extend that a little more, so those are precipitated withdrawals. This study took a look at 15 people with like very high opioid doses, probably opioid-induced hyperalgesia as well because of such high doses. And they're kind of chronic pain patients. And it took a look at kind of like trying to rapidly get them down so they could get a more reasonable tolerance and so they could um, reset and restart over with opioids. This is not an addiction population. And they took a look at self-reported questionnaires and they wanted to see what would happen. And what they saw is that like by using ketamine in this process to facilitate the rapid withdrawal, they actually experienced improved pain management. And they also had diminished or reduced opioid needs 6 months later. So a prolonged effect from this, this infusion of ketamine while they're there. It did diminish over time, but having an effect sustained over 6 months kind of speaks to like that protracted withdrawal being more comfortable for than one normally would be. Um, More recently, there's been a thought of looking at ketamine as a way to help not only getting on antagonists like kind of like the slides a couple before, but like also just getting onto buprenorphine. One of the big challenges now is there's a lot, well, there had been quite a bit of fentanyl on the street, and almost everybody was basically using fentanyl. And fentanyl, due to its lipophilic nature, really kind of can stay in the tissue for a really long time. And so I'm sure people in the audience experienced the difficult time getting someone inducted onto buprenorphine because they would have a precipitated withdrawal because there was still kind of fentanyl in their system. Even though you waited like a couple days, it was still kind of there. Um, and so this study took a look at people who were either on methadone, which typically is a challenge to kind of get onto buprenorphine, or who had been using a lot of fentanyl, and they were really reluctant to try Suboxone or buprenorphine at this point because they were really worried that, like when they, that it was going to make them feel worse, not better. And so they took a look in the study of giving sublingual ketamine to see if that would help facilitate getting onto buprenorphine. And the outcomes were basically success in getting onto the buprenorphine and what they reported. Of 37 patients that they prescribed and gave ketamine to, 13 they didn't see again. And so 65% they did see, and they reported that they did take the ketamine thereafter. So 35% giving ketamine and not knowing what they do with it or where it goes. Just a little caveat for this study. And for those who did take the ketamine, there was a pretty good rate of being able to initiate buprenorphine through an at-home induction. Like 2/3 of them were successfully able to do it. And they did report fairly uniformly that the ketamine did help lessen withdrawal and make withdrawal more comfortable. Um, And so may help getting over those hurdles of starting, like precipitated withdrawal. Another area that may be of interest is like co-occurring depression or anxiety with someone with substance use disorders. Ketamine may be helpful for treating the co-occurring conditions, which may have impact on the substance use trajectories as well. So this study took a look at intranasal ketamine for people with major depressive episode. So this is not major depressive disorder, which like S-ketamine or Spravato is approved to treat, but it could be major depressive disorder. It could also be a major depressive episode in someone with a bipolar disorder. And they were inpatients in a psychiatric facility, so they all had suicidal ideation. And they took a look at these patients and accepted patients who had active current alcohol use disorder. Currently, Spravato for treatment-resistant depression, active substance use is a contraindication. It kind of precludes proceeding at that time. And so this opens the possibility of people with active alcohol use disorder. And what they wanted to see was, does taking this ketamine in these populations, does it change suicidality and depression scores? And this is a one-time treatment of ketamine. And so not surprisingly, they didn't really notice any improvement in suicidal thoughts. Suicidal thoughts typically take a few treatments if it's intranasal. Unlike IV, where IV has shown that like suicidal ideation decreases 4 hours after the treatment, that's not the case with these other methods. And what they did see is that comparing people who had an alcohol use disorder, a comorbid, with people who didn't have it, people who didn't have the alcohol use disorder, they had better improvements, and it also seemed to have better correlations, meaning the depression and the suicidality both tracked positive at the same time. People who had an alcohol use disorder comorbid, what they saw was there was more variable response. So it's not all of them responded as well. And they also saw more uncorrelated trajectories, meaning the depression may have gone up, but the suicidal thoughts did not improve at all. So it wasn't as correlated of an improvement. Kind of interesting. So maybe differential effects that those two, like having comorbidity of alcohol use and at the same time may mitigate some of the effects. All right, let's go back to kind of addiction neurobiology real quick. And I'm going to talk about some other areas of this cycle. We talked about the withdrawal negative affect stage. That's where ketamine may be helpful for withdrawal symptoms and that protracted withdrawal. Let's talk about the other two stages. So the binge intoxication stage. Oh, I don't know if everything made it on this. We'll see what happens. Well, so the binge intoxication stage, I guess my ventral tegmental area is missing. Oh, there it is. Okay. So the ventral tegmental area, there's cell bodies there that project through the medial forebrain bundle up to the nucleus accumbens, and they release dopamine there. And that's has been postulated as the final common pathway of what makes a substance reinforcing or addictive. Substances that don't activate that system or don't do that aren't reinforcing. So like I haven't met people yet who are addicted to Prozac because Prozac doesn't increase dopamine in that area, but all substances do tend to do that. The substance initially does this, but over time, as the substance continues to affect this signaling, what happens is in the nucleus accumbens, in the striatum, that area, there is a progression of that pathway that goes more dorsally. So ventral is front, dorsal back. And what that means is that pattern of reinforcement goes more from thoughts to actions. So that dorsal migration is moving things from obsessive about it to compulsive use of it. So you start getting compulsive use, where it's now an ingrained behavior that gets reinforced, and it's automatic behaviors that start occurring. And so people literally are not at the wheel. They're, like their addiction is driving them to the crack house. They can't help themselves. They see it, and before they know it, they're using the substance. It's so automatic at that point. That's the binge intoxication stage, this highly active nucleus accumbens, dopamine, reward salience, motivation to do it again, do it again, do it again. And one way of thinking about it is that is what that nucleus accumbens is. It's like hedonic drive. It's that, like the devil on the shoulder saying, do it, do it, do it now. Kind of like Beavis and Butthead, fire, fire. Like that's the nucleus accumbens, the hedonic drive, doing those basal urges. The other stage, preoccupation, anticipation, that stage involves more frontal cortex areas as well as hippocampal areas. And what this is there are adaptations that happen to the frontal cortex as a result of continued use. What ends up happening is in the ventral medial prefrontal cortex, it's thought that that area is where a lot of cue-induced craving locates to. And so there is higher activation of the ventromedial prefrontal cortex, and that has projections that go down and activate the nucleus accumbens. And so a visual cue, something that's associated with use, quickly activates the reward pathway and that hedonic cycle, and seeking out the use rapidly gets instigated. Orbital frontal cortex, hippocampus, they also can have actions that can activate those areas through reward learning. And typically, we have this other circuit, rather than the ventral medial prefrontal cortex, the dorsolateral prefrontal cortex, which is typically kind of our executive functioning or top-down inhibition. And typically, the dorsolateral prefrontal cortex inhibits that active drive. And so that is kind of like what separates us from reptiles. The midbrain, where the nucleus accumbens is, where that hedonic drive, those basic instincts, like food, water, sex, those basic drives, a reptile doesn't have a cortex. They don't care if what they're doing. They'll go hump anything at any time. They don't have anything to mitigate that. They just act on urge at any time. Humans have this big cortex, and our cortex has evolved because we are social beings. We live with other people. It's not okay for Dr. Fellers to be humping something right next to me right now. That's not the appropriate time and place for that. And so I have my dorsolateral prefrontal cortex that says, oh, don't do that now. There's a better time to do that with your wife when you get back home, or whatnot. Like, we have these inhibiting impulses that say that might be what you want to do, but don't do it now. There's an appropriate time and place. Cognitive control is another way of looking at it. This circuit, the cognitive control, the dorsolateral prefrontal cortex in addiction, gets weakened over time. And so the consequence of that is there's less top-down control and less ability to impede impulses. And so people become more impulsive the longer they use substances. And so they start crossing lines that they said that they'd never cross. They make riskier decisions. And so it's really a setup for failure. They are restless, irritable, discontent, feel terrible. And then they get these urges, and then they're not able to suppress the urges as well because they're more impulsive. And then they get into that binge intoxication cycle and they can't break that cycle, and the whole process starts again. This is the kind of the abnormal homeostasis that gets established in addiction. And it's very hard to break that because all parts of it reinforce each other. The executive function, this is going to be my diagram, is typically, this is just diagrammatically what I just said. Dorsolateral prefrontal cortex offering cognitive control, saying, is the angel on the other shoulder saying, don't do that right now, it's not a good idea. And normally we would have a relatively balance of this, that we would make pretty good decisions when it comes to these things, balancing our drives with our cognitive control. However, in addiction, there's an overactivity of the nucleus accumbens, so it has a greater impact, and a diminution, whatever, that's a word I'm just probably making up now, less cognitive control. And so like it's very unbalanced and more impulsive and making riskier decisions. So what is the solution to addiction? Well, I'm just going to reflect back to you some paragraphs from 12-Step Recovery. The big book is about Alcoholics Anonymous. If when you honestly want to, you find you cannot quit entirely, or if when drinking you have little control over the amount you take, you are probably alcoholic. If that be the case, you may be suffering from an illness which only a spiritual experience will conquer. When that homeostasis of addiction is well established, it is very difficult to break out of that pattern. And this is kind of how 12-step programs describe it, that it is such an ingrained pattern, you need something to break out of that pattern. This is another quote by and they're kind of describing this solution, the solution for addiction, which they call a spiritual experience. Here and there, once in a while, alcoholics have had what are called vital spiritual experiences. To me, these are phenomena. They appear to be in the nature of huge emotional displacements and rearrangements. Ideas, emotions, and attitudes which were once the guiding forces of the lives of these men are suddenly cast aside, and a completely new set of conceptions and motives begin to dominate. This sounds very much like a complete rearrangement of the established pathway in addiction, that to break out of that cycle, you need to completely break that pattern that has been established. On the other hand, and strange as this may seem to those who do not understand, once a psychic change has occurred, the very same person who seemed doomed, who had so many problems and he despaired of solving them, suddenly finds himself easily able to control his desire for alcohol. Like there is such a, the solution that they're talking about is really kind of changing one's fundamental attitude and outlook upon life. And that's really what they're talking about. And in some ways, that solution is kind of like one way in which ketamine could potentially work. It could enable reestablishing normal homeostasis through plasticity, enhancing plasticity. So what is the ketamine experience? In addition to the dissociative effects, there's these other effects, the more psychedelic type effects. And these are sub-anesthetic doses, and this is some description of them, but they range from sub-anesthetic doses here, like which are typically mild dissociation, pleasure, maybe kind of not feeling odd, and then having more intense effects at medium doses where you kind of can have depersonalization and derealization, so kind of dissociation type things. diminishing of your things, more intense emotions and things like that. You can have even higher psychedelic effects where you can have near-death experience, like pretty profound, weird changes in consciousness. And then you can have like very high doses sometimes, like what I would say are anesthetic doses or like a K-hole, where you can have ego-dissolving transcendental experiences where your sense of self is completely lost. Sounds somewhat similar to a spiritual experience, maybe. I don't know. What's the evidence? Well, really interesting is like a lot of the work looking at ketamine for as a treatment of addiction started in Russia. So this is a clinical trial from Russia using sub-anesthetic ketamine to treat alcohol use disorder, kind of using this principle, kind of fundamental change of reaction and outlook. And total abstinence for more than 1 year was the outcome. And they had 111 in the ketamine arm where they gave a session, and then their normal treatment, they had 100. And significant amount of improvement in rate in abstinence at a year, 65.8%. Pretty profound improvement. Same group in Russia took a look at opioid use disorder, looking at ketamine. And what's important to know about the fact that it's done in Russia is they don't offer agonist treatment, neither buprenorphine nor methadone treatment. It's naltrexone or nothing only. And opioid use disorder is harshly criminalized, like people will be incarcerated for a long time, much longer than here. And so it's since the consequences are so dire, they actually do seem to have better outcomes. Like the Vivitrol data that got Vivitrol approved for opioid use disorder came from Russia because of that things. It was harder to recruit people in the US to do the naltrexone. This randomized double-blind clinical trial compared high dose and low dose. And at 6 months, it doesn't look great. The outcomes aren't nearly as good as they are for alcohol, like we all know with opioid use disorder. By 6 months, over 60% have already relapsed with a ketamine arm. So like, almost like 35 to 40% stay abstinent compared to about 15% in the treatment as usual. And so that is statistically significant. And at 1 year and 2 years, continued abstinence in the ketamine, so a sustained effect that lasts longer. They then took a look, well, if one session is helpful, what about a couple sessions? And so this is 1 session versus 3 sessions and taking a look at outcome at 1 year. And as you can see, better than the 22% that kind of like the previous slide kind of showed. Think about, 22%. They improve the rate to 50% with several treatments. So there may be an additive effect of having more sessions. Studies in the US examine ketamine in cocaine use disorder. And so this was a study, randomized crossover blunt, taking a look at with active placebo. So when active placebo is typically a benzodiazepine like lorazepam or midazolam that has psychotropic effects, but different psychotropic effects. And these are non-treatment seeking individuals. And they would just give them either the lorazepam or the ketamine, and then they would ask them, what is your motivation to quit? Like, do you feel motivated to stop using cocaine? And they would expose them to cocaine-related cues and ask them to rate their cravings for cocaine. during that session. And what they saw was pretty profound increases in motivation to change, to stop using, as well as improvements in craving, like less desire to use cocaine just by being exposed to a ketamine session. And they weren't treatment seeking. They took a look at the same study, and they, in addition to those other measures, they also took a look at subdomains of the psychotropic effects. So dissociation, which is one aspect of this, but also mysticism, which might be like more psychedelic type effect. And what they found is there's a strong correlation between the mysticism or the spiritual aspect of the experience and the motivation. So it's not the dissociative effect that really does it, that drives it. It's the psychedelic or mystical experience. This is another one where now in cocaine use disorder patients, a clinical laboratory study where they gave them crack cocaine in the lab and taught them, to give crack cocaine. And then they gave them either ketamine or midazolam, active control, and then gave them an option. You can have $11 or you can have some crack cocaine right now. And what they found is that in the ketamine group, they had suppression. They had, out of the 5 opportunities to choose, they, on average, only chose cocaine twice. Whereas with the midazolam or saline, they chose the cocaine 4 to 5 times. Um, um, and then Q reactivity is kind of like B. They saw like non-reactivity, like not being as activated by cues of it. They had less reactivity with ketamine. So like ketamine mitigated some of the excitatory effect of cues. Pretty interesting. And then they did, to follow this up, they did a randomized, double-blind, active, placebo-controlled study, single ketamine with mindfulness, so added therapy to it for treatment seekers. So those other ones were non-treatment seekers. And end of study abstinence and time to relapse. And what they found is that this is on days that like at about a month, there was improved survival or more people who stayed abstinent in the ketamine group, 40% versus, less than 10%. And the proportion of cocaine use, who had used cocaine, pretty consistently, the ketamine group over the weeks had a higher proportion, like were better able to not use. The same group took a look at ketamine and alcohol use disorder. Randomized, double-blind, placebo-controlled trial comparing single ketamine with motivational enhancement therapy, treatment-seeking individuals with alcohol, same basic measures. I kind of inverted the two, but basically you can see that this is 20 days out. The figure on the right, you see like 80% survival in the ketamine group versus 50% in the active control. And you can see post-days infusion that maybe they respond similar initially, but there's a sustained effect with the ketamine and nothing in the midazolam. And then another randomized, double-blind, placebo-controlled, now instead of 1 session, 3 sessions, more sessions are more helpful. And using relapse prevention therapy, outcomes, self-reported percentage of days abstinent at 6 months later. So instead of like a few weeks, a month later, 6 months later. And what they found in this study is over time, there were sustained effects with the ketamine. And you could see ketamine psychotherapy versus ketamine psychoeducation, which is kind of like would be considered a sham therapy. They were superior to placebo with therapy or sham therapy, and that psychotherapy did add more to just ketamine alone. And so having a sustained effect for 6 months after just 3 treatment sessions at the beginning. So this is pretty exciting, pretty interesting stuff. This is all preclinical data, not anything that is even in the realm of stage 3 clinical trials or anything like that, but kind of surprising. So in summary, I kind of just want to drive home ketamine. It's a dissociative anesthetic, primarily through NMDA receptor antagonism, but has multiple downstream actions that are probably responsible for the psychiatric as well as addiction mechanisms that are separate from the dissociative analgesia effects. And it does a lot of different signaling, transcriptional regulators, neurotrophic factors. And addiction itself is a process, is a cycle that develops through plasticity. Repeated exposure to the substance leads to rapid adaptation of cell pathways, development of tolerance, changes in synaptic density, strengthened behavioral patterns, and the associated learning of triggers and things. And that pattern, once established, is pretty strong and difficult to get out of. So strong that Alcoholics Anonymous says you need a spiritual experience. You're beyond human hope. And ketamine, like the 12-step process, is an experience to reestablish a normal homeostasis. The 12-step are one way to do it. That causes, it's kind of an engineered redeployment of personality, reorganization, realignment. And ketamine may share a similar thing. And that's the thought. The ketamine induces homeostatic plasticity, maybe allowing resetting and restabilizing of those imbalances of addiction. All right. Thank you. I'm sorry I didn't leave too much time, but I did make it through the slides. That's like actually amazing.
Thank you so much, Dr. Fellers. I want to, before we start going to questions, I want to direct everybody that the link for the survey is in the chat, along with our link for technical assistance. So if you would like to request specific coaching or technical assistance, you can do so there. And also, if we are unable to get to your question today, we keep them and we can try to answer them over email if that works for everyone. But our first question from Anna, can ketamine help with borderline personality disorder?
I'm not really an authority on all actions of it by any means. I do know that there's like a study looking at it in borderline personality disorder. I think there is an ongoing clinical trial right now. In general, I haven't seen too much that has taken a look at it. It's an interesting thought. Like maybe there are adaptations that have developed, kind of like this invalidating environment and these changes that have resulted to it and may allow new learning and new plasticity. Like, I don't know, like, kind of like a lot of things, this is so new that we want to apply it to everything right now. So like I would be a little cautious in doing it right now. I do think there is a danger. Like borderline personality disorder kind of gets its name by, like, they used to describe things as neurotic or psychotic, and borderline was on the boundary between those two, meaning at times they can act almost psychotic, at times they can act more neurotic. And something that is potentially destabilizing of ego boundaries and things like that may not be a good option for someone who has poor reality testing and ability to do that now. So I don't know, but I would say caution.
That's along the same lines. Cassandra wants to know, or is curious how it is about bipolar disorder, as it is her understanding that it is that Spravato is not recommended for bipolar disorder?
So that's true. So Spravato or S-ketamine, the like R and S isomers, is only approved for major depressive disorder and typically treatment resistant, which has several other definitions. Also for acute suicidal ideation in that context. It is not approved for bipolar disorder, where someone can have acute suicidal ideation, can also have major depressive episode. They only studied depression. I know they have studied quite extensively with ketamine, um, its use for depressive episodes and suicidality, and it has shown pretty robust effect. Notice that ketamine does not have an FDA approval for treatment-resistant depression. Spravato does. So like there haven't been those enough stage 3 studies or enough evidence to support its use systematically. It could be used off-label, which is basically using an approved medication for a non-approved indication. And so there is pretty good research that supports that. However, that is off-label prescribing and does lead you to more risk because it hasn't been established. There is potential more risk with the use of ketamine in individuals with bipolar disorder, particularly bipolar 1, since it has psychotometric effects. It can lead to worsening psychosis and instigate a manic episode or a psychotic episode much more likely. And so there is caution kind of applying it in that context. I would be surprised if the pharmaceutical company is not investigating using it in this context. They just haven't completed the studies. It needs more safety monitoring to be able to complete those studies for those reasons. I do think that it works in that context. It works a bit differently and doesn't often need continued treatment based on my clinical experience, but it would be considered off-label.
Mm. Um, Edward wants to know, has ketamine been studied with tobacco use disorder?
Um, Great question. I don't think I've seen it studied. There is that really great study of psilocybin for tobacco that showed really impressive data a year out. So it'd be interesting to see. I'm not aware of it at this time, but maybe it's a trial we could do. Hmm.
Yeah. I'm glad that the learning community is coordinating these things. Um, and then, can ketamine help with protracted grief?
I don't know, but I think grief has an awful lot in common with depression, persistent grief disorder now in the DSM, uh, um, um, pathological grief, um, is depression getting stuck. And so like it is a very interesting thing. Like I kind of see it, like at least my view of it is kind of that way, that maybe it would be good for conditions that people kind of get stuck in, that they've kind of developed this pattern and it's a self-reinforcing pattern that they're stuck in and it may loosen things up. It's kind of been the thought about how ECT also works, that ECT may facilitate plasticity and neurogenesis and rearrange pathways. Um, I don't know, but I would bet that it would be helpful. Yeah.
Well, and so I'm so sorry that we cannot get to all of these questions in person, but we can handle them over email. Thank you so much, Dr. Fellers, for this wonderful presentation. It's very enlightening. Thank you so much to everyone who joined us today. Like I said, the survey link is in the chat. The slides and the survey link will be sent out in the follow-up email. And if you do have any other questions that were not already put in the chat, you can forward them on to me and I can pass